Terrific. Thank you so much.
Thank you.
To both speakers. And what we have ahead of us now is an ample section of time for Q&A and discussion. I think really rich presentations that have started us off on our journey today. So be thinking of your questions, and I'll start off with one to both speakers, and then I'll be looking around the room. So I would just really begin by saying that these two presentations, I think, beautifully complement one another, really, with the sort of a health system approach that Dr. Gottlieb outlined, and then thinking at the same time, really, from a state and a policy level, what are the levers that can be used, and what a multiplicity of them to advance population health at the statewide level. So I would really ask sort of complementary questions to the two speakers. Really, first to Dr. Gottlieb. You know, from your research, are you observing effective approaches that in some of the 5 A's that you outlined, or using earlier language in terms of informed sort of health, social risk-informed care, that is having an impact on some of the outcomes that you're tracking most closely, let's say at your own institution or other systems that you're studying?
So it's a good question, Mark. The research that we have really kind of seen predominantly in this space has been around the assistance track. So there's a lot of enthusiasm around alignment and investment and advocacy, but I wouldn't say that the research has really focused there. But there's a lot of really important work that's happening there. That's in part because the research is hard to do on multi-sectoral partnerships. And while I think that there is research in different places and in different disciplines around adjustment strategies, and again, that's sort of, being aware of social risk factors and changing care according to information on them. Nobody, as I kind of alluded to in my presentation, nobody has really pulled those out and said that this is a body of health services research that needs lifting up. It seems much more disparate. So the place, by and large, where we see sort of, okay, people are wrapping their arms around kind of evidence generation is really focused on assistance strategies. And I think that's in part because it's health services research, which is a sort of very established thing, it's right at that intersection of sort of needing social services. So I think it's an evidence-based medicine. It fits into that realm or in that milieu, but we just haven't really applied those same kinds of methodologies or other methodologies, because I think that there are other methodologies that are necessary for the more community-oriented activity. I hope that answers your question.
I think it does. I mean, I know that we're not going back to slides during the Q&A period, but when you showed that the model with the 5 A's, what you're really saying is that the undergirding assessment piece is being pretty thoroughly studied, which in other language essentially translates to screening and ascertainment, I would say, and then that and that assistance also, but less so on sort of adjusting health care delivery to meet the social risks that that have been identified through assessment.
Yeah, I think that's true. I didn't actually talk about awareness or screening strategies, but I think that is absolutely true. We have seen quite a bit of research, although I think we need some more, on awareness strategies and then also on assistance strategies, but not so much on the other side.
Thank you. And then to Deputy Secretary Money, a couple of really thinking about the approach at the state level and the many sectors that you've brought in, and then coning in a little bit on the healthcare sector. Is it at the table with you? To what extent are health systems really sort of on board and engaged in the work that you're describing, as opposed to kind of hunkering down to see what they what's going to be visited upon them?
So health systems have been at the table from the very beginning. Actually, our Medicaid transformation is an outgrowth of a desire by the legislature prior to this administration, actually moving from a fee-for-service Medicaid to a Medicaid managed care approach. Mm-hmm. At that point, the health systems, and I was part of the systems, mm-hmm. we've been with the community health centers, really stepped forward and said, if we're going to take this approach, then we don't need to take it with just a healthcare approach in mind. We really need to look at what are the other factors mm-hmm. that are impacting health, particularly if we're moving towards a value-based reimbursement model, then we need to consider that these social drivers of health are going to impact our ability to move the needle on healthcare outcomes. And unless we address those, then we're never going to be able to be successful in any type of a capitated model. And so, we were right at the very beginning preaching this message and really holding the department to it. As Governor Cooper came into office and brought in Secretary Mandy Cohen, the model really shifted, and the emphasis on social determinants of health and this healthy opportunities piece really came to light. Yeah. And in that, the department was very transparent in their intent. You can go to our website and you can see many white papers that were crafted, that were essentially put out for public comment. And we invited health systems. We invited the community to react. And the model was adjusted to the first 1115 waiver submission that happened out of the McCrory administration, and then to the revision out of the Cooper administration through Secretary Cohen that really refined this process. So the community, the state, the providers, the healthcare system were really at the table at every stage of the process.
Yeah, it's key. Yeah, thank you. I'm scanning. Questions from the audience? Yes, over here.
Sandy Magnan. So thank you so much to both of you for this great start off to our workshop. So as I listened and I was thinking about social risk versus social needs, kind of that language part, that how do we make certain that we as systems and communities that we're listening to what the needs are versus what we assess as risk. So that's one question. The other thing that came to my mind is I see Gary Gunderson sitting over there, having written the book Leading Indicators of Life, that we often in healthcare focus on the deficits instead of focusing on what assets. So I wonder what your thoughts are about how do we combine this, looking at the deficits, the risk, with what are the assets that patients and or communities have. So those two thoughts.
Right. I think it really starts with, as you said before, listening to communities, and Laura mentioned that as well. She talked about aligning activities and community priorities. It really kind of goes back to if you know folks that have been in the Peace Corps, one of their approaches is what does the community need, right? You focus on what their desired needs are first. And I think in many instances, we come in with our data sets and our analytics and our geo maps, and we say, here's your problem and here's what you need, and we don't take the time to listen. And the communities have solutions, and when you have the community invested in the solutions and the outcome, you're much more likely to have success because they're going to put it on their backs because it's their desired outcome, and they will help see it through. And I think in many instances, we need to put a greater emphasis on taking a step back and really having those conversations to make sure that we're in alignment, that we really are meeting the needs of the community first, before we launch into our agenda, and to make sure that our agenda and the community's agenda, it's the community's agenda at the end of the day. And as you said, assets-based approach, assuring that communities have the respect for the work that they've done and the leaders that they have that have provided them with guidance along the way, and making sure that you're engaging those leaders, those community leaders, not necessarily the political leaders, but the real leaders in the community early on in the process.
Laura, did you
I
want?
think,
Yeah.
Mark, well, I really appreciate that question, Sonny. I totally agree with Ben, and I think that you can take that. I mean, you sort of set it up for us in the question, but you can take that same frame and apply it to the healthcare delivery side intervention. So the reason we wrote that Milbank paper was where we lay out definitions, potential definitions that people, the idea was that this was iterative, right? So we'd lay out some potential definitions, and hopefully people will grapple with them or really think about exactly these questions. But we did distinguish between social risks and social needs. And the reason we did that was we're seeing in the awareness literature, the sort of literature on screening, that many people endorse what we kind of think of as social risk factors, but then actually don't want any assistance around those social risk factors. And nobody's really studied that. We actually have a current call for proposals out, sort of trying to catalyze some more research in this area through Siren. But the idea there is, well, why are they not? Are those social risks, things that we call social risks, are they not rising to the level of a priority for patients? Do they have no hope or expectation that the healthcare delivery system should be involved in them? Like, what are the reasons there? Do they really just not think of them as a need? That's just sort of those are the kind of big questions there. And I think distinguishing between them kind of makes us really acknowledge that social risk screening is exactly what it is. It's just screening, and that doesn't mean that we need to do something about it in particularly not in the context of healthcare, but also that we need to pay more attention to not just going through the motions of screening, but really thinking about what is the priority of the patient. And that's why we then would say that would, identifying the social needs is really the ultimate goal, or the first step of the ultimate goal.
Thank you very much. Yes.
Hi, I'm Jennifer Little from Klamath County Public Health in Oregon. And we're a rural community. And so my question actually for you, Mr. Money, and also for Ms. Gottlieb is, how do you see a lot of these programs and frameworks unfolding differently in the urban versus the rural environments, particularly for you for the healthy opportunities, because that looks very different in a rural and an urban environment, and then also with the 5 A's, and again, how that looks different, and how some of the strategies around it, and some maybe how the evaluation is different, and stakeholder engagement. So that's my question.
That's an excellent question. And I think it's very appropriate for North Carolina, because we're both an urban and a rural state. And as you said, rural needs are different than urban needs. When we think about transportation systems, in urban areas, it's a different model in rural areas. And so what we've done is we've engaged our Office of Rural Health to work with counties, and we're sort of a county-based state, to work with counties, particularly those rural counties, on their discrete approaches to those 4 domains, because every county is going to have a different set of assets and is going to have a different set of challenges. And we don't even have the same set of rural in North Carolina. So we have eastern North Carolina, which is flat, which is coastal, which is subject to hurricanes, floods, where you have very sparsely populated areas, but then you have these clusters. A lot of poverty out there. And you go to the mountains, And you have small pockets, you have large areas, not largely populated, but you have mountainous areas which are difficult to navigate. So it's a different terrain, different cultures, different racial demographics, and different assets as well. And so we're trying to make sure that the approach that we take is really unique and individualized to the counties that we're addressing. We've got there's a community health center in the eastern part of the state that's done some unique things with transportation systems, utilizing the resources that currently exist. You know, church vans and agency vans, and creating really a sort of a network. They also did some unique work in the food insecurity area, where they have started with developing community gardens. There's a faith-based organization that's done that and taken it a step further in developing honeybee hives, so training residents of the community to be beekeepers. So it's income development, it's ecologically responsible, and it's also contributing to the sustainable agriculture in the area. So really thinking about, as mentioned before, what are the assets, looking at the needs, and then crafting an individualized approach to the area that you're working within.
I don't know if, I mean, I feel like, Jennifer, it's such an important question. I don't know that I have much to add, except that I think that the only one of the 5 A's that I would say probably doesn't change so considerably based on kind of asset mapping is probably the adjustment strategies. If you're really looking at differences across rural and urban populations. So, you know, I like to think, as a family doctor, I like to think, how do I get my own wheelhouse in order? You know, what am I going to do differently in the context of care? And that's where I really think that adjustment strategies need to play a more central role. And, you know, a lot of rural providers are doing this every day, but we aren't necessarily doing it for every patient or always thinking about it. I think in rural settings, a lot of times the providers that are there are more attuned to social risk factors and thinking about it in different ways, but I don't think that's a universal, and I don't think our health systems are necessarily set up to do that any better in rural areas than they are in urban areas. But anyway, I would just sort of pull that one out a little bit and sort of say, maybe that one is just not as different in rural versus urban, but then it may still be affected by that, and I think I really appreciate that you're surfacing that as, hey, this is one thing that we just can't forget about. This is really, really important to think about across the framework.
I will add, as we think about rural areas and those critical access hospitals and what we're seeing in demise of critical access hospitals in terms of the current model not being necessarily viable, I think this creates an opportunity for us to reimagine what critical access hospitals and rural healthcare actually looks like. And in that reimagining, incorporate the components of addressing social risk factors, developing strategies that address social drivers of health, and creating and crafting models that are unique and viable within the communities in which they're designed to serve.
Thanks for these great questions. Keep them coming.
Buenos días, mi nombre es Lourdes Rodriguez, and I'm with the Dell Medical School at the University of Texas in Austin. And I feel such privilege to be in this room today listening to the both of you. My question is about transformation. And one of the things that Laura mentioned was this thorny, hairy tension of how the social sector may feel like there's so much emphasis on taking care of social needs within clinical settings that maybe they get the short end of the stick in terms of allocation of resources. So how do we transform the way that we invest in services in a way that when we refer people out, we send a backpack of money from the healthcare sector towards the social service sector? And the other transformation is about our minds around piloting as a serial a series of unfortunate events or fortunate events, right? That once we pilot something, we're so happy, but it doesn't get integrated into the new way of doing things, right? Because pilots are sometimes construed as new extra money for doing something new, but when the money's gone, then there's no transformation. So I would love to hear your thoughts on those two things, on how do we put the money where the value is accrued, and how do we transform from serial pilot mentality to transforming the way that we do things. Thank you.
Those are excellent questions, and those are really top of mind for us as we roll into our effort. Data is going to be really critical, okay? Because you can demonstrate that investment in, and I'll use Laura's example, providing a refrigerator, right, for someone that needs to have their insulin refrigerated, and the cost savings of a refrigerator that maybe costs $200, right? And then you have somebody to install it. Maybe that's another $50, deliver it, install it. Versus what would happen if they, failed to take their insulin or their insulin wasn't viable and they went to the emergency room. I mean, just the ambulance ride, right? You could buy like a top of the line, I don't know, Viking refrigerator, right, for your house, just for the cost of the ambulance. Forget even going to the ER. So it's really being able to demonstrate that. And then, one of the things we're going to find, particularly as we press up against this issue of affordable housing, which is just diminishing nationwide, is we're going to have this sort of feedback loop, right, where we send people with a referral for affordable housing, and what happens? They get on the list, and the list can be like 2.5 years. And now we're sending more people through this process because we have this, electronic system now, right? So now your list is 3.5 years, 4 years. But because our emphasis is going to be on data, we'll have that data to be able to say, this is a more accurate picture of the housing needs than we've ever had before. This is the result of putting someone who was homeless that had multiple chronic conditions in housing that, let's say, it cost high-end, $1,000 a month to put them in housing. But they were going to the ER twice a month. You just paid for the housing, So showing the data, showing the cost benefit, and then really putting it in front of policymakers saying, this is math, okay? This is an opinion, it's mathematics. And the mathematics say we need to make these investments if we're going to have the cost savings and the outcomes that we desire. Thank you.
So, Mark, can I add? I agree with Ben, obviously. But I have a couple of things that I want to add. And one is actually, I love this refrigeration example because it turns out that and I use it frequently, so this is it's just something that I've been struggling with. But it's actually it's a great example because it's so nuanced. So it turns out that insulin, well, certain types of insulin, but the kinds of insulin that we talk about needing refrigeration, they only need to be refrigerated if you're not going to use them within the next 28 days. So hence, we probably should be making recommendations for people who don't have refrigerators to just, we probably should be saying just give people insulin for 30 days if they don't have a refrigerator instead of a 3-month refill, which sometimes is easier for providers but doesn't help patients, or is more helpful for patients, but if they don't have a refrigerator, their insulin may not be as good. So this is an example where we could avoid exacerbating the problems of the social conditions if we knew enough to change what we're doing in practice, or we could make the decision to help people get a refrigerator. But you can see how the math gets more complicated in that situation because maybe the value is in changing what our practice is. Like maybe there's more value in giving people shorter prescriptions if there's going to be a problem with the refrigeration or if it's not possible to get a refrigerator. And this is where the math is only so good. Like I still want people to have refrigerators because I don't because it's a good thing. It's the right thing to do. So, and it indicates other kinds of stability. So it just gets so complicated when we think about it in those terms. Okay, so the math aside, to just go back to your really excellent question, one of the things that I have been most excited about in this field is that it's changed. In the last 5 years, more states like North Carolina have come to the table. And CMMI is now doing this big demonstration, and there's lots more energy around what are the payment models that can make this sustainable. So in the National Academies report that will be released next week, one of the big chapters is it will be on sort of financing strategies to move from pilot, like this, I think you're highlighting the sort of death by 1,000 pilots, right? To move from pilot to sustainability, because I think this is a real problem. Anyway, those are my two additions, but totally agree with Ben, and I think both of us are agreeing with you that these are important challenges that we're facing in this kind of the rapidly changing field.
Thank
I
you
would just
both.
also add that having a refrigerator will increase your ability to store fresh fruits and vegetables, which are also helpful for diabetes. Great question.
Gary.
Thank you, and thank you, Ben, for being here. For those who don't know Ben, first of all,
Your name?
Gary Gunderson. I'm a member of the Roundtable. First, I want to thank you for calling the name of Dr. John Hatch and the long tradition in North Carolina that knows an enormous amount about the ground game of social determinants. The comment I want to make is you and I are quite similar. We're working for institutions that are very different from the ones we came from. And the reality is in North Carolina, the real challenge here is alignment between institutions and political persuasions that have very different values, including respect for the poor themselves. The policy that you and your colleagues with impeccable values are charged with implementing was developed under a former governor, former legislature, whose almost sole concern was control of cost. Poor people cost way too much, they're inconvenient, and so we got to do this cheaper. We'll bring in out-of-state insurance companies, and maybe they can control the cost better than our own Department of Health and Human Services. And what you're actually doing is trying to implement a program that was driven out of values that actually are hostile to the values you have of trying to see that people who are poor and vulnerable actually have their health advanced. So I just sort of named that, and one of the critical challenges on a not-for-profit provider system and you in government is the intermediary agencies are essentially for-profit insurance companies. And this total transformation that is described and focused on social determinants is still essentially administered by out-of-state for-profit companies. And so we're actually doing all this on less money, not more money. Now we're taking money out of the state for for-profit companies. For 3 of the 4 are sending profit out of the state. So those of us here are trying to do a radical transformation, actually with significant less money and under pretty severe constraints. The last critical question I would have for you as a person who's worked in community health is very place-oriented, neighborhood-oriented, does lots and lots and lots of investments in community change that are not keyed and financed patient by patient, member by member. And this plan is still essentially a medicalized vision of individual patients who then get an expanded set of services. It's not really focused on neighborhood investment yet. There may be some wiggle room in the pilots, but overwhelmingly what we see is a more medical approach to a broader array of services still provided to patients, not engaging neighborhoods. And a lot of the tension inside the roundtable is exactly how do we understand the tension between neighborhood, place-based change-making and more comprehensive care of individuals.
Gary, that was a lot of questions. So I'm going to try to take it on place by place. And Gary, is one of my great collaborators in North Carolina. And so, we, for a long time, were sort of on the outside of this model, critiquing. And now I'm on the inside of the model. And so Gary is kind of saying, so now that you're on the inside, what do you think about these issues we've been talking about for the last 5 years? Well, where we are with the prepaid health plans and the for-profit MCOs is kind of where we are. It's statute, right? It happened in 2015. This is where we are. And this is where a lot of states are as well. Fortunately, there's a medical loss ratio so that it caps the profits that the prepaid health plans can actually make. And we've created some models that actually incentivize their reinvestment into communities, right? It gives them some certain advantages. But we want them to have the ability to do the right thing in this approach. And we hope that they will take some of the lessons learned from other states and apply them. We also know that, going to a value-based model implies a certain level of risk. And so they're holding the risk. And there's a capitalization that needs to happen to, enable a company to be able to manage that level of risk. So I think there's an appropriate role for-profit entities in this. It's going to take all of us to really move the needle. In terms of what this does to the social service system, that it's a medicalized model, it's medicalized from the standpoint of Medicaid being the impetus and being, really one of the largest funding sources for the initiative and particularly the pilots. But remember that NC Care 360 electronic data set is available to anybody. You can actually go online and search the database. So you don't have to be a healthcare organization. You can be a food bank that runs across somebody that's homeless, and you can go on NC Care 360 and refer them to a housing provider. Or if you're an organization that provides housing and you see someone has landlord issues, you can refer them to an entity that will provide them some legal services. So the intent is for there to be no wrong door, but the ability for human service organizations to be able to track beneficiaries, to track patients across the system. And that's regardless of payer source. So not just a Medicaid beneficiary, but someone that's uninsured, someone that may be insured, doesn't have access to these services. Because, just because you're technically insured, a lot of technically insured people are actually underinsured and don't have the kind of insurance that covers them for the things that they really need. So Mandy Cohen, our secretary, is a master lemonade maker. She is taking some sour lemons and turning them into some sweet lemonade. And we're going to learn along the way. And we're very fortunate that CMS is willing to go on this journey with us.
I'm mindful of that. We have about 2-3 minutes left. So I see a couple people still at the mics. Maybe a brief question?
Alyssa Crawford from Mathematica. Building off that last point, because I actually heard Mandy Cohen speaking last week about some of the work that's happening in North Carolina, and one of the things she said that I thought was really powerful was, I want to learn from the mistakes we've had in healthcare data when we talk about how to approach social determinants of health data. And one of the things I'm concerned about is within healthcare, there's been a lot of effort, good effort, valuable effort at addressing the low-hanging fruit, the easier solutions to problems. And in social determinants of health, I think there's a very similar pattern where a lot of the interventions are looking for the things that are easier to show quantitatively the real ROI. But some of the bigger problems like systematic racism, social isolation, those are going to take much longer term investments, which are harder to convince politicians and policymakers about because the time frames are going to be longer. So have you seen any promising practices in how we can build as a community working on this the momentum towards those bigger picture efforts, or try to use data to really tell that story in advance so we can have those bigger picture conversations while we also look for the low-hanging fruit?
Wow, that's another
Yeah.
big question. You know, when I think about promising practices, go across the pond. I mean, I feel like where we are compared to other Western nations is far behind. And I think we could learn a lot and advance much quicker if we take on some approaches from other countries that have done this more successfully. I think that in and of itself requires a certain amount of national humility to say that, you know, while we have made significant advances in leading the world in, you know, healthcare innovation and research and technologies and pharmaceuticals and all this really cutting edge stuff, you know, when it comes to the blocking and tackling, the basics of making sure that our healthcare is equitable, that the population overall is improving in just overall life expectancy. We've gone down in life expectancy, right? I mean, our outcomes, you know this from just a comparison to other nations, are far less than the amount of money we invest in the system compared to other countries. So I think that's the thing we need to do. But one of the biggest issues that we face in the United States is income inequality. And a lot of the income inequality does stem from historic and systematic racism. It stems from really the inability. There's no county in America where someone making the U.S. minimum wage can actually afford housing. You know, how can that be? You know, I mean, we hear a lot about homelessness, you know, coming from down the street. And that is, let's wipe people off the streets, not let's provide them with kind of housing that they need. So I think that we are coming to a point in this country where we need to honestly decide who we are and what we're going to do. And quite honestly, climate change and the growing heat that is impacting the planet is moving people from equatorial countries northward. We're seeing that in Central and South America with the migration. We're seeing it in Africa to the Mediterranean, to Western Europe and the migration. We're going to see that more and more. And that really does create an ethical question of who we are, who do we say we are, who do we want to be, and how do we get there? You know, and the money is in the system. The money is there. It's how that money gets distributed that I think is the moral question of our generation.
I want to thank, really thank our two initial panelists, Dr. Laura Gottlieb and Deputy Secretary Ben Money, for really framing the day and rapidly deepening the conversation, really beyond expectation. So, a warm round of applause.